will invite Dr. Rony Mathew. He's a senior interventional cardiologist at our department at DC Hospital. He's got vast experience in OCT to deliver his talk. He'll be talking on OCT guided bifurcation stenting. Dr. Rony, please.
Thank you, Dr. Ashokan. Thank you, Dr. Khanna, for the invite. I know we are running way behind schedule, and I will try and make it very brief. So I've been asked to speak on the key advantages of OCT guided bifurcation. And of course, we listened to Dr. Sanjeev with this very good talk on MLD max. So I'm going to restrict to bifurcations only. So why do we need imaging, first of all? And I think it's important to understand that bifurcation is a complex three-dimensional structure where there's a lot of overlapping and foreshortening in angiography. And therefore, there are inherent limitations in the quantitative assessment. And why OCT? Because intravascular OCT has a clear advantage because it depicts the osteal lesion in a bifurcation without the misleading 2D appearance. And as you see here, you see the ostium very clearly without an overlap compared to the conventional angiogram. In addition, with the 3D, the OCT, you can assess the side branch ostium from a three-dimensional reconstruction of the main vessel pullback. So of course, there are a lot of key advantages, but I'm going to only speak of one because I think that's the only time that we have for this, and that's for the wire recross. Of course, there is a lot of reasons why people think this may not be necessary, but trying to put it very simply, if you've got a provisional strategy with a single crossover stenting, I think choosing the right cell matters when you go to the side branch, because as is shown here, if you go the distally, you do a distal cross, then when you kiss, the strut displaces two struts towards the inner curvature of the side branch, and this provides a metal flap to prevent plaque recoil to the side branch ostia. Like in this particular case, a Medina 111, we do a main vessel and a pot, you do see the side branch having a lesion. Now, all that needs is, as you see here, we have recrossed it, and we go back and show you, we have recrossed it from the distal strut here, as you can see here. That's a distal strut crossing, and that's very important that you do a distal strut crossing. And then you open that, kiss it, and once you kiss that, you get a good result. And look at the OCT post-kissing. Pre-kissing, you had the strut right across, so you cross distally, and you push that strut away, and you can see it very clearly over here, that strut being pushed out. Now, when we are talking about crush strategy, that's for a two-stent strategy. We always say it should not be distal, it should be the proximal and center cell. The reason is, because as you see here, if you cross distally and you take the balloon, you're going to pull this strut proximally, and you would find an area that is uncovered by the stent. And that is why there's a significant gap. So it should always be a center or a proximal cross. Now let's have a look at this DK crush that I did. A 111. So here we do a side branch stenting, which is the first step. And then once the side branch is stented, you crush that side branch with an adequate sized balloon. You cross proximally, you do the first kiss, and then you do the main vessel stenting. And now what we did here is we did a proximal cross, because you can do a proximal or a mid cross, and we did a final kiss. Now I want to show you how this 3D looks. It looks excellent. But when you look at this 3D, you see, because we did a proximal cross, we have got a large amount of metallic neocarina that you can see in the red over here in the carine. And if you look there, because when we crossed proximally, we pushed this strut distally. And 3D, that's exactly how it looks. We crossed proximally, as you see on the left panel. And when you do a kiss, the crossing proximally, you create a large metallic neocarina which lies into the main vessel. So for a decay crush, I believe you should not go proximally. For a two-stent strategy, you must do a mid-cross. Like look at this particular case. A Medina 011, we did a D1 stent. We crushed the side branch stent. We did the first recross, did the first kiss, did the main vessel stent, did a pot, did a second recross, and this final cross was mid. And I will show you as it runs, but anyway, I'll show you the 3D reconstruction of that. You look at the wire going, it's going not proximally here, but it goes mid. The advantage of it going mid is when you open this with a kiss, not only is the angiography result good, you find a lumen that is well opened with no metallic neocarina. Therefore, when you do a decay crush, you do a mid cross. So to recapitulate, if you're going to do a provisional stenting, always a distal cross. If you're doing a two-stent strategy with a crush, always do a mid cross. And that is where you get the best results. The next part is to check the struts across the side branch in provisional. And this has been something that everybody asks in every conference. Is a kiss mandatory in a provisional strategy? So here, in this case, you put a stent across from the left main to the LAD. In this case also, you put a stent across from LM to LAD. You get a good result. Do you need to kiss this? And see, in this case, there are no struts across the side branch. In this case, there are struts across the side branch. So what I'm trying to show you is that in such cases, you should kiss when there are struts across the side branch. A simple case where we did an LM crossover stenting. I'm going to go to this OCT. You look at this. There is strut across. But the result is excellent. So we leave this. This was 4 years back. This gentleman comes back with angina. And if you look at his angio, you do find a lesion right at the ostium. We have about 7 such similar cases. And if you look at the OCT, LM OCT pullback, you find that the circumflex ostium is divided into 2. When you do a pullback from the circumflex, the catheter has gone through one ostium, you can see the other ostium. And three-dimensionally, this is how it is. The single circumflex ostium is divided into 2 because there is a neo-intimal growth across the stent that was across the side branch. And this caused flow limitation with angina. Another case that I want to show you, a cipher that was put in. Similarly, when you look at this run that goes by, you see that the side branch over here in the circumflex has been covered with neo-intima, and you see it being covered and opened, having 3 distinct openings on the circumflex, all because there's been neo-intimal growth. In fact, this was presented at the European Bifurcation Club, and in the 15th consensus document, they incorporated this case of ours, and they said that struts across the ostium continues to be debated. The floating struts supports the development of a fenestrated restenosis. Of course, there are other advantages with the optimal kiss and optimal pot, which I'm sure I'll get an opportunity next time to talk to you. And in the interest of time, I would thank you all. And these are some of the key benefits, some of the benefits of OCT in bifurcation, in addition to what Dr. Sanjeev Roy showed you. Thank you all for your kind attention. Thank you.
Thank you, Dr. Rony, for the excellent talk. And we'll have a discussion at the end of the session.